In many places around the world, if a physician orders an ultrasound of the heart, an echocardiogram, it may take several months till it can be scheduled. And this is where some of the visionary work of a portable device that uses AI can turn that upside down.
If you've ever had symptoms that pointed to a potential heart problem, it's possible you've had an ultrasound of your heart. It's called an echocardiogram to diagnose or rule out cardiac issues. An echocardiogram creates pictures of the blood flow and structures of the heart. Well, now doctors have another tool to help them analyze those pictures, seeing the heart more clearly with AI. That's ahead on this episode of Tomorrow's Cure, a podcast from Mayo Clinic that brings the future of medicine to the present. I'm Kathy Wurzer. Thank you for joining us. We are speaking today with two leaders working to merge the worlds of AI and cardiac ultrasound. It's going to be an exciting conversation with Dr. Paul Friedman. He is a cardiac electrophysiologist and the chair of the Department of Cardiology at Mayo Clinic in Rochester, Minnesota. Also with us is Davide Wortman. He's the CEO of Ultrasound. That's a company applying AI learning to cardiac ultrasounds. We should tell you that Mayo Clinic is now an investor in Ultrasound. Both are jointly developing algorithms to analyze and interpret these images of the heart. Dr. Friedman, Mr. Wortman, thank you for joining us today.
Thank you for having me.
Thank you, Kathy. It's a pleasure.
Appreciate your time. Thank you so much. Say, Dr. Friedman, I did some study on you, and you did your undergraduate work in electrical engineering, and then you went to medical school and focused on the heart. Why did you decide to do that?
I've always loved the way the humanities and sciences come together in medicine, and the blend of engineering specifically with cardiovascular medicine is a natural fit. There's a lot, both of electrical and mechanical engineering, if you will, that's in the heart through evolution. My own area is specifically cardiac electrophysiology, which involves using pacemakers and defibrillators and catheter ablation. And so having a good understanding of the engineering and physics is particularly helpful in that space. And as we'll talk about today with regards to ultrasound imaging and AI, also those fundamental concepts travel across the sciences very well.
Mr. Wortman, you did your undergrad in computer science prior to working with Ultrasound, and I know you founded a solar technology company that provides solar energy to rural communities. Tell me a little bit about that.
Yes, I started my career as a software engineer and really saw the emergence of internet and then enterprise software. And around 2013, I felt I want to do something that will make an impact, not just build a company around enterprise software. And I started a company called Loomis Global, which brought electricity to places that didn't have access to the grid. So we're talking about 1 billion people in emerging markets that lack access to electricity. And we built a system based on a solar energy and service that changed their lives. And really that led me to what I'm doing today, because I learned how technology can impact businesses' lives and make people much more productive. And that's exactly what we're trying to do here.
Was there a moment, some kind of an aha moment for you when you made the switch from solar energy to healthcare that seems like an interesting jump?
The aha moment happened to me around 2020 when I met a very talented team from the Weizmann Institute at NYU that showed me how ultrasound can be utilized much more using AI. And it was very similar to what I've seen with solar energy. When you bring power to the edges, when you bring technology to the edges, suddenly beautiful things come up and people get skill sets and capabilities that they never had before.
For those who haven't had one, doctor, how do you describe an echocardiogram, the procedure, to a patient?
Sure. So the echocardiogram is a procedure where a probe, a small cylinder, is placed on your chest with some gel, and it sends sound waves into your body, and it records the sound waves that come out, and it creates pictures of the heart. Historically, a cardiologist was a doctor with a stethoscope. We still are. But essentially, think of this analogy. If you're listening to a river and hearing the water rush, you might picture in your mind's eye what the river looks like, if there's a waterfall, if there are rocks in it. But if you see an image of it, all of a sudden you have a deep, detailed, concrete, actionable, if you needed to navigate down the river, understanding of the lay of the land and of the water. That's the difference between a stethoscope and an ultrasound. We actually see the heart muscle. We see how it moves. We see how the valves move using what's called Doppler, which is the effect where, the sound of a train changes as it comes versus it goes. That same phenomenon can be used to calculate the speed of blood flow across the various chambers and tell us how well the heart is working and whether there are any lesions or abnormalities.
Would you both say that an echocardiogram is a good tool for early detection of potential cardiac problems?
The short answer and the long answer is yes. The more detailed answer is that historically, because they have been somewhat expensive, difficult to get, for an average person, it would mean being off work for a couple of hours. And there aren't enough people to acquire and read the images, so that in many places around the world, if a physician orders an ultrasound of the heart, an echocardiogram, it may take several months till it can be scheduled. So it hasn't been used necessarily for first-line screening because of those barriers, but more when you suspect something to then get what can be a definitive test. And this is where some of the visionary work of a portable device that uses AI can turn that upside down by making it inexpensive, available at the edges.
How does the use of AI then enhance echocardiology?
Yeah, so let's speak about two very important trends. One is we see increase in cardiac disease because of obesity, because of diabetes and other reasons. But we don't see the number of specialists increase at the same rate. So the number of cardiologists doesn't increase, and the number of sonographers who are doing the echo doesn't increase at that pace. The other trend we're seeing is that people are not coming back after COVID, back to their positions. So it's becoming even more expensive to get experts. And this is where AI comes in. AI can take any generalist and make them very similar to a specialist within a very short time of training. And we're talking about hours instead of months. So this is where AI is revolutionizing healthcare. And this example, I think, is a great one, because if we can increase the number of people that can do diagnostics for cardiac disease, we can increase the number of patients that get to treatment on time. And that's a challenge for the healthcare system today.
Doctor, would you like to speak to this?
Yeah. If you think about a diagnostic ultrasound or echocardiogram of the heart, two main components. One is acquiring the images. Someone puts the probe on the chest, but they have to know how to point it and what adjustments to make to get the images. That training process typically is a year to a year and a half. That person is called a sonographer. Then there's typically a physician who reads the images. And that also is a many, many years long training. And so getting through all of those processes is where we have the bottleneck. There are two components to the AI, if we dig into it specifically. One of them is an AI guide in real time. And this is the expertise that Davidi and Ultrasight have developed, where when a human is holding a probe on the chest, it shows you graphically to move the probe up, to angle it, to push a little harder. In a trial we have done in collaboration with Ultrasight, we've found that a college student with a few hours of guidance can learn to follow those probes and acquire diagnostic quality images to answer critical questions. Is the heart pump normal in its strength? Are the valves normal? The second component is, how about reading those images? Because if we want it for a screening tool, we want at least a first pass look to say, is there serious disease here or not? And our group has developed tools to read the ultrasound images to identify abnormalities so that we can reassure someone on the spot things look okay. That's our goal once this process is completed, versus say, looks like there's an abnormality here. You need a proper full-scale echocardiogram, the test of which there's limited resources. And so we're trying to best get the right people to the right test. That's one example of how it could be used.
Okay, you just said they've tested it with college students, and I'm wondering, why is that a good thing to have people who may be novices at this be able to do a test like this? Davidi, does this make it more accessible to patients?
Absolutely. And what Dr. Friedman said is very important, because we are separating between the reading of the images which must be done eventually by a cardiologist, or someone who's certified to do the reading. And there are tools that we can build that make the reading faster and better. And then we are talking about the acquisition of the images. So think about your watch, right? You can get EKG signals from your watch that eventually are going to be interpreted by a cardiologist, right? So we're not replacing the experts. We're giving them more data from more patients faster than ever before. So AI is a 10x accelerator for access that gives much better data at the right time. That's the key.
And I would add to that, the analogy I like to think of is as follows. If you're going for a walk at night in the dark, you would take a flashlight so you can see the path in front of you. But you're still using your eyes to guide you and make those decisions. And each step of the way, AI is doing the same thing. That is, it's that flashlight that helps us peer deeper into that dark night, but it doesn't replace our eyes or our interpretation. So that screening test that, say, a trained college student or other person is doing is a first pass screen, but it won't replace, once you see there's a problem, the experience of expert professionals in performing the diagnostic test. But there's just not enough capacity. So why don't we send those people who would really benefit from the expert test to that test, and those people who can be reassured, let's reassure them and tell them, look, you don't need to wait for that expensive, more difficult to obtain, more complex test.
Measurements can be a little different, sonographer to sonographer. And I'm wondering, does that make interpretation of the results difficult? Does AI then help?
Yes, absolutely. AI is leveling the playing field because what AI does is ensures the quality of image is consistent and is not operator dependent. So if you and I use the same software, we'll get the same results. And that's really where AI plays, an important role in standardization.
It actually provides the framework to allow more consistent data acquisition and reading. It doesn't replace human interpretation and action, but it can provide a common groundwork for that consistency.
How could this be used in places that echocardiograms are not used right now or are not readily available at this point? How might this maybe expand the technology for patients? Davide?
Sure. So today, people may live 6-8 hours away from a center of excellence that has the right, cardiologists and the right sonographers. And for many people to go and spend a day or two to get the exam is just too much. If we could do it closer to where they live, we can get the detection of disease in time for treatment. And that's a big problem that, we have to address as a healthcare system.
Dr. Freeman, do you see this in your practice?
Yeah, for both in the U.S., in rural communities, and in many countries outside of the U.S., healthcare is really aggregated in large urban centers. And for people who have limited mobility, limited economic means to travel because of jobs or children or other family concerns, accessing care can be difficult. There are barriers. The other thing is just the cost of the equipment. The high-end, expensive echocardiography equipment that's used in a tertiary medical center is not widely available in primary care clinics. On the other hand, there are now ultrasound probes that can be adapted to a tablet or a smartphone that can allow, again, we're talking about screening tests, not the definitive final test that maybe a cardiologist would use. But that kind of screening is very powerful, again, because someone who may not have known that they had an important heart condition for which there are evidence-based approved treatments gets that knowledge, and it can change the course of the trajectory of their life. On the other hand, you could also reassure somebody who might be having symptoms that are very common, like palpitations, which often are from benign causes.
I've done some reading on this. Both of you have talked about how this could lead to a democratization of the echocardiogram. Interesting word to use, democratization, democratizing an echocardiogram. You wouldn't think of that. So maybe, Doctor, could you expand on that?
Well, look, I think many of us feel healthcare should be accessible to everyone, but we also recognize in the real world there are barriers in terms of expense, access, availability, and the healthcare system is also um, bursting at the seams. I have not met one physician who says, "Oh, I have lots of free time. I'm happy to, see you at any time," right? And it's not from lack of desire or interest in helping individuals. It's just only so many hours in the day. And so the more we can leverage people who maybe haven't had that length of training, who are interested in helping and serving and taking jobs that maybe require less training to do that initial screening, the more we can effectively use the scarcer resources. And so that's the form of democratization, to make widely available in a just way, in a way that improves the human condition more broadly, and not having the inherent restrictions that are in place just from the organic evolution of how society has developed, and healthcare delivery in particular.
Let's talk about the process of creating this new technology. Dividi, how exciting is this? And give us a sense of what you have to go through when you're developing something like this.
So this is by far the most exciting company and the most exciting technology I've been part of. And I've worked for probably 5 different companies, most of them startups. You really feel like you're creating a new way of care. And, it starts with a very small team, about 3 people in 2020, that come with an idea. And taking that idea into the commercial aspects and making it a solution is really where my passion is. So it's about the team, building a great team that is very passionate about this. And it's about the partnerships. And we're fortunate, to partner with the Mayo Clinic, because Mayo Clinic and Dr. Friedman, they bring this kind of passion, even though they're big, they're not a startup, right? They exist for, 200 years almost. They bring this kind of passion to healthcare. Let's think out of the box. So that is what I'm finding as a very exciting moment in healthcare, where, small startup, combines forces with a very large and, experienced healthcare system and starting to do something completely different.
I want to respond a little bit because much of what Davidi just said really resonated with me. And I just want to tell you that early in my career as a cardiologist, I was amazed with what medical science could do to help people with heart disease. But as I started to get some gray hair and really look at the big picture, I thought, what can we do to prevent these things from happening so I don't have to treat them? But if you know it's there before something bad happens, you can prevent heart failure. You can prevent hospitalization because someone is gasping for air because you knew it was coming, and you could change the course by intervening. And these projects, the development of these AI tools, inspire a passion in us in a similar sort of way. These are the ones where I get that excited 1 a.m. email. I've got a great idea. What if we do it this way? Because the challenges are really important, right? We're working to improve the human condition, and you work together in teams with physicians, with scientists, with engineers, and all of us bringing different perspectives, bringing humanity together in a way to say, how can we work together to solve this problem?
And Dr. Friedman, I'm curious, as you were working to develop this, I want to ask about what you had to go through to think about data sets and the diversity of those data sets.
We're fortunate to have large, robust data sets that are incredibly well labeled. Most of the approaches we've taken now for interpretation of images has been involved in what we call supervised learning. That means that the images have been classified by an expert, and so we're fortunate to have very detailed, meticulous classification. We started initially with electrocardiograms, electrical signals of the heart, a simpler signal, and where we have roughly 9 million ECGs embedded in the electronic medical record, and in patients who had given their consent for research, and they're all anonymized because we have to protect patients' privacy. That's front and center to everything we do. We were able to determine through artificial intelligence the presence of disease. And once we developed that model, we're now taking it to ultrasound, which is a more sophisticated signal with even more information in it. But we have the benefit, again, of roughly 9 million digitally acquired echocardiograms with very detailed and annotated measurements and reports, where experts looked at it and said, here are the measurements of the left ventricle, the main pumping chamber. Here is the strength of the heart pump, the ejection fraction. Here's what we measure as the flow velocity. And then here are my final impressions. So we know both the detailed specific measurements as well as the clinician's interpretation. And we can use all of that to train networks to look at the images. So there's a lot of work involved in developing it and then in testing it, in vetting it, and validating it.
I think we've done a good job in terms of talking about the opportunities of integrating this into existing platforms, but I'm curious about the challenges. What do you see in front of you, doctor, when it comes to maybe integrating this into platforms?
For training networks, you need access to data. But then even once it's used, and if something is part of the electronic medical record, you can't necessarily easily and immediately push data in and out of an EMR because it's a very secure, appropriately secure system so that all of our medical information is kept private as it should be. So there are technical hurdles in some instances in integrating it.
I believe, in the system today, when you give a new skill set to generalists, some of them would say, I don't want a new skill set. I'm good with what I have right now. And for some of them, they would require some certification, training, etc. And I think the challenge for us as a healthcare system is to empower, more clinicians to do jobs that they never used to do before, and giving them the confidence. And this is where, I believe AI tools can help create education that doesn't take years or months. It takes, less than a day. And the question is there openness, for that kind of, new approach to skill sets and medicine?
That's an interesting question, Davidi. Dr. Friedman, what do you think about that? Is there an openness?
Yeah, I think with any new technology, adoption is always an issue. And that comes in part because of just the busyness and multiple demands on clinicians. And so the first question is there evidence showing that it's benefit? People want to say, look, I'm willing to learn something new if it's clear it will help. And so we need to develop the evidence base to motivate people to take on those skills. The second thing, of course, is once that evidence is developed, the fact that it's made so much simpler opens up the pool of people who can participate in the process.
Davidi, I understand that Ultrasound has been granted FDA clearance for this tech. What's that process been like?
So our experience taking software through the FDA has been closely working with the experts on the FDA side to design, the clinical studies in such a way that will support patients all over the US and support clinicians that are different types of users. So we tested it in 3 centers on 240 patients, and that's, a lot of work. But what it can ensure us and ensure the clinicians is this is tested software that was really non-biased and doesn't, fit a certain pool of patients.
So when do you think clinicians may be able to use this, the handheld device, the software?
It's usable today in its what I'll call earlier incarnations. So the ability to have AI guide image acquisition utilizing a mobile form factor like a smartphone or tablet is available right now. And so that anyone in a medical practice who wants to have a receptionist or someone else in their practice learn to do part of that, to acquire the preliminary images, can undertake that process. The process of a more end-to-end, where the image is acquired and interpreted preliminarily to screen for diseases, is evolving and developing, and I think will be more robust and mature in its impact on screening populations, for example, I would say within the next 2 to 3 years, with varying capabilities present now already, and that those I think will see a lot of growth.
I'm wondering as I'm listening to you both, is it possible that sometime in the future this could be used by a home health care aide or a caregiver to a cardiac patient at home?
This is the future. Diagnostic tools like Ultrasound that are low cost are going to be future of healthcare and disease detection. And we already see some emerging things going on today, like we have chemotherapy at home that's being given by people in the Mayo Clinic. That's a very cool idea because patient experience is so much better and the risk is lower and even the cost may be lower. But they have to do echocardiogram every X number of weeks. And that's something that requires them to go to the hospital, risk of getting, other disease, and cost, of course. So if we can train the nurse to do both tests, giving the chemotherapy and doing the echocardiogram, we are improving patient experience, compliance, and reducing cost.
I think home healthcare aides will be able to do ultrasounds with the AI guidance for image acquisition and send them back then to someone to interpret. And the question is, at some point, will people be doing these on themselves? I think that's a little more provocative, and I think we're farther from that point. But there are some scenarios where people might be interested in doing that.
This is a transparency question for you, Dr. Friedman. How much do you tell a patient regarding the use of AI? Is there an obligation to tell a patient that the care they're getting is AI assisted?
That's I guess the obligation is a good question for an ethicist. I always let people know what tools we're using and what we're doing. I think that honesty is fundamental and transparency is fundamental to a patient-doctor relationship. All of us are human and we benefit from our experience over time. But I'm confident that all of us on this podcast and all of our listeners are using the internet to Google things, to look up results, right? All of us has used chatbots and whatnot because we want to be the best at what we're doing. We want to use every tool at our disposal. At the same time, to use them well, we have to recognize both what they're good at and what their potential limitations are.
I was thinking, listening to you talk in our conversation about how you started when you were back in medical school, put it into some context, just in the incredible changes that you've seen in your career. And now we're talking about the potential of having caregivers do an echocardiogram on their patient at home.
If we step back and look at the big picture, healthcare is about humanity and health. And we want to detect conditions sooner so we can prevent bad things from happening to people. And we want to allow the time that healthcare providers, that physicians and nurse practitioners and physicians' assistants spend talking to someone rather than dealing with technological systems. And I think all of these advances that liberate us from the more clerical type activities of whether it's making a measurement or entering something in a computer, let us step back and look at the person we're talking to, understand their needs, concerns, and health status, and be better able to serve them and hopefully debulk, deburden, and depressurize the healthcare system so that we can spend more time delivering quality care. And a big part of that is enhanced diagnostics, which is what we've been talking about all day today. The therapeutics are also making dramatic improvements. And in order to couple those dramatic improvements and how we can treat people, we need to identify who's healthy and who has a condition that we should be thinking about and treating. So I think there's a lot of room for optimism. At the same time, we have to be wide-eyed, careful, and mindful of the potential pitfalls so that we can sidestep them and make sure we have the tools working for us the way we want.
Davide, would you like to make a final comment on this?
Yes, I think the adoption of new technologies in healthcare is going to help patients to get better care and better access. And the collaboration between, the human side of medicine, as Dr. Friedman described, which is, I agree, is so important. And the ability to get great data on the patient that allows you to make better decisions is where technology is becoming, such an important part. Because for the patient, they want to talk to the best expert, and the best expert wants the best data. And this is where you need to connect the dots, right? And distance doesn't matter anymore. That's the beauty about, using new types of devices and new types of connectivity and technology to make the distance, basically be anywhere. And that's why I'm so excited. This is happening, now we're living in an age where healthcare is going to accelerate care in new ways.
Gentlemen, this has been a fascinating conversation. I appreciate your time. We've been talking to Dr. Paul Friedman with Mayo Clinic and Davide Wortman. He's the CEO of Ultrasight. Thank you so much.
Thank you, Kathy.
Thank you, Kathy.
Tomorrow's Cure is a co-production of Mayo Clinic and PRX. Our producers are Deborah Balthazar and David Newtown. The show is edited by Genevieve Sponsler. Our sound engineer is Tommy Bazarian. Our theme was composed and produced by Terrence Bernardo. Tony Carlson is our production manager, and our executive producer is Jocelyn Gonzalez. Special thanks to Preston Spire for audiovisual production support. Be sure to follow Tomorrow's Cure wherever you get your podcasts. I'm your host, Kathy Wurzer. Thank you so much for listening.